Hello and welcome here to the next session of our MarS webinar. It's Thursday, April 29th in the year 21. And as always, at the last Thursday of the month at 9 p.m. German time, we have our webinar about the topics for market access and reimbursement. My name is Lutz Vollmer and I will be your moderator tonight. So just before we come here to our topic about the access to German hospitals, let me give you some general informations. So who are we? So MarS, the Market Access and Pricing Strategy, is the German-speaking market access experts for your topics about pricing and reimbursement strategies for reimbursement submissions, like for the Federal Joint Committee in Germany. Of course, we do also the new DIGAs in Germany, for the Swiss BRG or the Austrian Hauptverband. And also, of course, we support you with price negotiations, including our cool virtual reality boot camps here. So we developed some real nice training also when we can meet here in face-to-face. And also, if you need help with some health economics also, well, please feel free to contact us. So as always, and that's on the next slide, you're welcome here for our webinar, and feel free to ask questions after the presentation, which is about half an hour. We will have plenty of time for your questions, and just feel free to write them here, either in the chat function or in the Q&A session here in our function in the Zoom webinar that Zoom provides here in the webinar. And as always, and that's the first question, the slides and also recording of the video will be provided afterwards. So if you miss one, just check out on our website. It's www.marketaccess-pricingstrategy.de. And then here you find up in the corner the webinar session. And also check out, now we have a webinar calendar. Something new here, tremendous guests on our show. In May, Professor Jürgen Wasem is joining us. He's the former head of the arbitration board. So we are really lucky to have him here. That will be a great show, a great webinar. When we discuss him about the arbitration board. That will be really cool. Stefan, did we already negotiate the time when we start with him?
He tried to negotiate, but I think we're stuck with the 9 p.m. CET time. Okay. Yes, of course. Okay. But he tried it.
Okay. So see, he's a really cool, fantastic professor, lots of knowledge, really tremendous analytic person. So we're happy to have him here on our webinars. And then in June, we also have a wonderful person, Ariane Schenk from the Bitkom will be there with 1 year of DIGA. Then we have the DIGA again, the topics. Well, that's a really fantastic topics, lots of development there. And then in July, we have the federal elections in Germany. It's Professor Uwe Wagschal from the University of Freiburg. And we are talking with him about the federal elections, the implications also for the health sector. And if you didn't get it yet, so the news, the Green Party actually has higher rates for the next election than the Conservatives. And that's in federal elections in Germany. So that will be a really political thriller here, what we will have in the federal elections here in September. So that's our upcoming webinars. And if you missed one of our webinars, like the one with Remo last month, the Alps, the cheese, and the banks, also with a small recommendation of Remo about his favorite kinds of cheese he likes. So check it out on our webpage. It's all on a YouTube channel. If you go on our webpage already, it's pretty easy. So you can subscribe our YouTube channels. But now we are turning tonight here. Yeah, exactly. That was our YouTube channel. And now tonight we have a really special guest. Willi Woellner is here from the MediClinics in Bad Wildungen. And we are happy that he, left all the statistic behind him and could join tonight. So he gives us a real insight. Willi, happy that you are here. 2 words about you, or 2 sentences actually.
Yeah, hi. I'm also happy to be here today, and yeah, I will try to give you a small overview later about the German hospital market. You know, it's really complex and full of bureaucracy, like a lot of things in Germany. So, yeah.
Wonderful. And then, of course, we have my boss here, my big boss is here, Stefan Walzer, the founder and the CEO of MarS. Welcome to Weil am Rhein. Stefan, happy that you're here. And now we have a wonderful topic, access to German hospitals. And do you lead us now through the pathways of this?
Of course, Lutz. Thank you very much, as always, Lutz, for the introduction. Thank you, Willi, also for joining us. I think will be a really fantastic kind of discussion, and I think really insight as well directly out of the clinics in Germany. So before we come to Willi, I think what we try to do now in the next probably 20-25 minutes is probably show you the most important pathways when you think about healthcare market access in Germany, and especially then here, obviously focusing on hospitals. I think also important why I have probably said tried, or I will try to do so. I think it is rather complex. I mean, it might look that, you know, you have heard here about the NUP and maybe some of the OPS and maybe something else, but I think there are a lot of different pathways. And I think we will probably not even touch base on all of the different kind of opportunities getting into the German hospitals tonight. So just generally maybe as well, just to give you a kind of, let's say, environment and also the kind of, let's say, the mood as well, how and where the kind of, let's call it directly hurdles for market access, and especially with a focus on hospitals you might see and have in Germany. To give you as well a kind of flavor here, I think we still have a bit more than 100 individual statutory health insurance funds. Health insurance funds from the statutory side are basically covering around 80% of the German population. Then we have as well a good number of private insurances. But tonight, with all of the different pathways, we will follow on the statutory pathway, because I think that's a quite clear and I think the quite, let's say, straightforward pathway also, and obviously to target the bigger population. Also important, especially when we think and speak about the hospitals, we still have the differentiation between the different regions here, the so-called Länder. So we have as well there, we have 16 different regions, and also within those 16 different regions we have, which is then more targeting, let's say, the outpatient part, the 17 associations of the statutory health insurance physicians. And I think, Willi, you will know that as well better than me. Also, hospitals are, for example, offering outpatient service, obviously, but this is not what we'll cover today. You see already quite a lot of different stakeholders just when we mention the number of insurances and then also the regions, and we'll see that as well in a couple of minutes, why also the regions are important, depending maybe also which kind of product you might have in your hands in order to bring that to German hospitals. Finally, or maybe pre-finally, I think it's also important to still have in mind that the budgets are clearly split as well in Germany, still between the inpatient and the outpatient setting. I think there are different ways how this should be eased. I think there are different pilot studies, different kind of committees being set up. And I think also for the upcoming elections, Lutz, you mentioned it as well for that webinar in July. I think there are also a lot of discussions, let's say even suggestions how this might maybe also be eased towards, or let's say maybe starting with a new government as well. But for now, I think we have a clear kind of separation. That's also the important kind of mindset you would probably as well need to keep in mind when you speak with the different stakeholders. And finally, we also do not have the simple and the one hospital. We have also different owners of hospitals. I mean, we have private hospitals with different private hospital chains. We have big kind of university academic hospitals, and we have as well smaller hospitals also within different kind of ownerships, which might also have an impact obviously on the different kind of pathways. I'll touch base on that in a minute. So before, let's say, going through the different kind of pathways, and I will also just very briefly go into the Hospital Future Act. I think that's something you might have heard already, and I think we can probably already as well jump a bit further on. There is a good chunk of money which is currently being, let's say, tried to bring into the market for hospitals in order to also push, especially digitalization. I would say digitalization and especially infrastructure in the next couple of years. I think, Willi, you might as well probably speak about that one. I think you see here a couple of different, let's say, buckets where also that kind of Hospital Future Act might be important. Infrastructure and processes, that's also an important component, especially maybe if you have, for example, also a digital kind of product in your hand, but also obviously different kind of medical devices, potentially even diagnostics. That also obviously depends a lot what you finally have. I mean, digital record, patient portals might be as well a touch base on. And you see as well, obviously, the kind of famous telemedicine. Important just here now, and we will not go further into the details here, but the important thing to mention as well for the Hospital Future Act is there is the kind of deadlines, heavy deadlines, let's say, within the different regions, which are happening in the next couple of very few months, where hospitals would need to submit their kind of suggestions, how to basically, let's say, bring and lift up their kind of infrastructure with those different buckets in the next couple of years. Just a concept which is then, or which would then need to be submitted further as a full kind of, let's say, suggestion and the kind of report, what would really be requested also in terms of budget, obviously, next year. Besides the Hospital Future Act, let's maybe also spend a couple of minutes on the different kind of, let's say, finances, which are important still from the infrastructure perspective, because that's obviously important also when you think about what and which kind of product I might have in my hands and who do I need maybe to target for, because ultimately you would also need to understand who is really then the payer. And we're probably speaking here a bit broader about the payers, not so much only the insurance companies, what we normally speak about, but here you will directly see that we have that depend also, we call it on different kind of levels. If we start with the macro level, I mean, you see that the Hospital Future Act is obviously one opportunity, but also we put that into brackets in the Innovation Fund. Why is it in brackets? Because normally, and I think that is my understanding at least, that it was set up that in order to bring the inpatient and the outpatient more in an integrated way together. And that is, I think, what is especially being funded for already since a couple of years with a couple of millions of euros. But at least if you have, let's say, something in that kind of sphere with a kind of interconnection between both, let's say, parts, the inpatient, the outpatient, I think the Innovation Fund could also be an interesting kind of pathway. On a meso level, you have the individual states, which are ultimately responsible for the funding of investments in hospitals. Sounds so easy. Sounds, if you think maybe about also Germany, quite straightforward. It is not. I think maybe, Willi, you might as well spend some words on that. But I think my understanding is especially those kind of investments by the different regions have been, let's say, not really missed, or the goals have been missed, let's say, in the last couple of years. So that's also why I think a lot of German hospitals might have, let's say, financial kind of issues, especially when we speak about the infrastructure. And on a micro level, you get, again, what I said a couple of minutes ago, the kind of potential impact by the different ownerships. So you see basically, if that's basically a private chain, there might be maybe a bit of a broader opportunity also to fund a given kind of investment for infrastructure, but also for other kind of devices or important kind of, let's say, products which might be needed for the hospital. Sometimes maybe also obviously to differentiate versus other hospitals. And finally, before we come to the official pathways, there's also and still the possibility, let's say, for individual contracts between hospitals and insurances. I would rather call that integrated care contracts. And that's also obviously very special. I mean, there are a lot of those different kind of, let's say, contracts, for example, also between insurances, between a hospital, and also between outpatient providers. But there might be also other kind of concepts. I think at the end of the day, what is really important, if you would really want to go that kind of pathway, I think our kind of experience is to really focus on the care pathway. I think you need to show why and how the kind of care pathway is being improved for the individual patient, for group of patients. And then you need obviously at least one health insurance fund, one health insurance company. My experience is more, I think you need to have 2+, so at least 3 health insurance companies in order to come up with such a kind of contract. It's at least something always keep in mind, because sometimes you might also have let's say, longer kind of pathways, which we'll see as well in the next couple of minutes, which might then basically mean that there might not be, let's call it the kind of cash flow, obviously, in the short run, meaning that kind of solution with a kind of integrated care contract could be potentially also a market access pathway. So before we are then jumping now into the different, let's say, official pathways, also and always to be remembered, we have not only the kind of clear differentiation between inpatient and outpatients in the budget perspective, but we have that also from a legal perspective. So for the inpatients, all of the procedures are basically permitted with the reservation of prohibition, which basically means if you have a product for the inpatient use, you could sell it to the hospital. And it's more kind of discussion, obviously, with the hospital, with the management of hospital, and also with the purchasers of hospital. For example, also with persons like Willi. In the outpatient setting, it's the other way around. All innovation procedures or all procedures per se, everything new is basically, first of all, prohibited until they have been officially approved, and will not touch base tonight on the outpatient, to really focus on the inpatient setting. Still, we need to see, because if you have a new product, I think everybody would at least imagine that a lot of times they bring good benefits, and with a good benefit, you might also have a higher price, and hence you would also need to see how this is also financed for in the system. So if you have here the CE certified products, that's quite clear. We take that as given. Without a CE certification, I think, let's call it the least, it would be very difficult to get into anything like a market access. But if you see basically the kind of red box below, we start with the first kind of bucket on the kind of pathways to go in the German system. So there is the OPS, we're covering that in a minute. Then there's the so-called on-top payment, the NUP, Zusatzentgelt. Some of you might know that application. And as well, there's something like a bit of a new, I think in the meantime, I think a lot of you might know that already. I think there's also a benefit assessment for high-risk procedures correlated and interrelated and integrated into the kind of NUP submission. Before we then go as well to the method assessment and the experimental coverage. But first of all, let's say, with the kind of regular kind of pathways, I would call it. And I think a lot of you might know that as well. So to start, very simple, how is basically the German system being financed? I think at the end of the day, you have a disease, which is coded according to the ICD codes. And then you have a procedure. So basically what is being done with the patient, which is organized through the OPS codes. And finally, if you bring both together, you have a specific DRG, which basically gives you a lump sum for the patient for those two, let's say, components we have just discussed about. So what if you, for example, bring up a new kind of, let's say, procedure or a new kind of, probably kind of new product or a therapy in a way into the German market, where you just think there is no OPS code available, or it's at least not as specific as you might want to have it. So an OPS code basically just shows you in a kind of, let's call it from an accounting perspective, what has been done with the patient. So which kind of procedure has been applied. It has normally, or let's say a lot of times, no direct implications on the revenue, meaning on the DRG value, what you get. So why should we maybe as well want to do that? One, I think that might be as well something maybe Willi as well will discuss shortly, but when the different budget discussions will happen between the hospitals and the health insurance, let's say, side, also the so-called NUPs, and we'll come to that on the next slide, will be negotiated. And obviously, if there's something newly introduced in the hospital system, obviously the payer side would as well want to know how many of those cases, for example, procedures, have been then applied in the last couple of years. So with an adequate OPS, it's obviously easier to follow how many times the new procedure has been done. How is it done? There's a simple application form. It is released in December, and it needs to be submitted in February of a given year. Important here, the company cannot submit it. It's the responsible German Medical Society, which is then the responsible person to be involved. Important as well. As a side note, no RCT data are required for the OPS application. In case you have a product which is new, that's one important thing, new, innovative, and secondly, more expensive, which is a bit different to everything else what we have in mind when we think about payers. This kind of concept here at this stage is first of all on the organization. Let's say I would say it from an accountant's perspective, the organization of hospitals. So it's being checked for if one, the kind of product is already included somehow in the system. So if it's new, it's not. And secondly, if it's already adequately funded. If it is adequately funded, meaning it's part of the DRG or could be paid out of the DRG, then you don't have, let's say, a quite high likelihood in order to get, let's say, be rejected for, or let's say, with a NUP submission. Otherwise, the NUP needs to be submitted by the individual hospitals. So not only by the company, that's not.
Stefan, I think we lost your voice. Nope, it's not there. Okay. So we have here the inpatient reimbursement NUPs, and you see here also the NUP application. And I hear that Stefan will be back.
Up. Do you hear me again?
No, we can hear you.
Okay, sorry. Okay. I don't know what happened. I just, let's say, put my microphone off and just I'm now taking the microphone off the computer. So what I just wanted to say, I think for the NUP, and I don't know when you lost me, but I think for the NUP, it's very important to basically have the two components. It needs to be new and innovative, and it needs to be more expensive because otherwise you will not get a positive NUP decision. NUPs needs to be submitted by each individual hospital every year until the so-called INEC. You see that, that's the institution which is organizing, let's say, the whole kind of hospital environment here, is deciding that the NUP might be turned into a permanent NUP, which is then the entrance door in order to submit the additional funding for that procedure. And that will happen during the annual budget negotiations for each hospital. Timelines, you see those, and then you have the different decision makers. You have the so-called DIMD on the OPS, and you have the INEC on the NUP. So what will happen if the product is, for example, a high-risk class product? And we touch base what a high-risk product is in a second as well. First of all, and that's what we normally as well recommend, in order to get, let's say, quite, let's say, certainty if your product is a high-risk product, it's always advisable in order to consult as well the GBA directly, in order then as well to ask the GBA if your product is seen as a high-risk product. Do that already, let's say, roughly 10 months before the actual NUP submission, in order to have an answer by summer, because that is normally as well where hospitals would like to know if the product is a high-risk product. Why do they want to know that? You see that in the second column in here, where you see the gray box which says hospital. They need as well to submit the different information about the current scientific knowledge, meaning they would as well want to have the current kind of evidence of your product, which would then need to be submitted for the whole kind of procedure. So what is a high risk method? You see the different kind of, let's say, classification which need to go in there. I mean, the first question, is it a new theoretical scientific concept? Already that is a bit tricky. Second point is obviously it needs to be a high risk class medical device. The NUP needs to be requested for the first time. And finally, it needs to be specifically invasive. If those could be basically, let's say, checkboxed, then the likelihood is quite high that the GBA would, let's say, decide on your product that it's a high risk method. Why is that important? Because, sorry. It is important because the GBA is then doing I would call it a quick benefit assessment. And finally, you see here at the very bottom here, there is a kind of different benefit outcomes there. So if the benefit can be seen as proven, then it goes basically in the kind of normal pathway where it just says, yes, it can be reimbursed, and it goes into the system. If it's sufficiently proven, but with potential, not sufficiently proven, sorry, but with the potential, then it goes into the experimental coverage, which we'll cover as well a bit later on. And finally, and I think this is, to me, still a bit of an issue here, if there's no benefit and no potential being seen, the decision is basically to exclude the method of the German market. Let's just see. I think the important point here is that only a minority of products have been seen so far as high-risk product, but it's at least something to keep in mind and also to be checked for before you submit, and maybe as well you as a hospital obviously then would submit, or you as a company would basically need to prepare for such submissions and support the hospitals. So this was the kind of standard procedures. And if you think this is what was already maybe a bit tricky, we can jump into the so-called method assessment. Very nice kind of graphic. I mean, as Lutz said, the slides will be available, so I would not go into the kind of details. But at the end of the day, it's important that the GBA is then assessing new methods, basically according to evidence-based methods. And important here also, you see it here at the very end of the kind of right-hand arrow, you have a total of 2, depending which kind of law is basically applicable, or up to 3 years until you have a kind of decision when everything basically goes in there. Important maybe also for some of you, the so-called IQWiC is also involved. And I think IQWiC, I think everybody who has been already been in touch with the IQWiC, I think they are really keen on the methodological kind of piece of the evidence-based medicine. So what could be kind of scenarios as a result for the method assessment? I mean, just have a look. There are basically 4 different outcomes. It's quite clear, I think, if the benefit, the necessity, and the economics, let's call it, which are the kind of core components of the legal, of the underlying legal basis in Germany, then the method will be included as a regular service of the statutory health insurance fund. If the evidence is not yet sufficient, but studies are ongoing, the consultation will be interrupted. So that means you would first need to, let's say, finish your studies, and then you need to further submit the new evidence until a decision is then basically being taken. If the benefit is not sufficiently proven, but there's a potential, we're again back to the experimental coverage, which will come directly after that kind of pathway. And if there's no benefit proven and no potential, we're again at that kind of red card in a way, which would mean that the service will be excluded from the statutory health insurance market, meaning from reimbursement, also then here from the inpatient market. I think GBA classifies the evidence according to its rules of procedures. And as we said already, as a couple of seconds ago, I think they're just following the evidence-based method, and obviously RCT are the highest evidence base. So if you then just expand that even further, you have then the experimental coverage, which is just a way where also you as a company can directly get in contact with the GBA, meaning there's an application form which needs to be filled out. So you could basically say, look, this is my new procedure. You need to explain it. You need to also explain where you see the potential. And then you would basically say, look, I would like to go into the kind of experimental coverage procedure and pathway with the GBA, which means that they would basically open up that kind of concept. What does that mean? You start on the very left-hand side, which is the first box, determination of the potential, which is then being basically said, if the GBA does not see a potential, this is not a pathway. If they say, yes, there's a potential, then the GBA would basically see, yes, we can go into the experimental coverage, which basically means that there would be a draft directive, a so-called directive, where they would just generally say, look, this is what we want to do. We want to do an experimental coverage. They would also open it up to the public domain, obviously, especially to the scientific public domain, where they would also ask for opinions, how to run and start such a kind of experimental coverage study. That is basically being done in a written statement form. They would then obviously discuss it in the committee. Then there's a resolution of the directive, first a draft resolution of the directive, where also, again, a written statement opportunity is possible, and also followed by an oral hearing. And finally, if that is basically then all done and all heard, the resolution will be done and finalized. And you go basically into the very right-hand next box, where the experimental coverage would basically start off. Important here maybe as well to mention is that the experimental coverage study is being funded by the statutory health insurance system, meaning that all patients also entering those kind of studies will be paid for by the system, meaning if you have a procedure which is part of that experimental coverage study, that this is being paid for, that. So that is basically a kind of early access as well into the system while further generating evidence. The downside of that is a bit the kind of timing. You see already that there might be around 3 months until you get the potential decision. Then there might be another kind of 3 months until the draft directive is basically being even just be published. Could even take a bit longer, right? I think we had already the experience that it took the GBA 9 months to draft the directive, and then you have another roughly 6 to 8 months in order to come up with a kind of final resolution. So finally, you see that this is already roughly 1.5 to 2 years until, 1 to 1.5 years until the resolution of the directive is being done. And then the experimental coverage needs to be started within the next 18 months. So that's then also where you could, for example, work with the different clinical study centers. So having said all of those different pathways, I think you see it is rather complex, and it's even just a small proportion of that. And I think, Willi, I think we have known already now for quite a while. I think we have known each other as well from the German Health Economic Association, where we have as well been driving a bit the Inpatient committee there, and I think you are now heading this. I think the terminology of the committee has now changed, but I think ultimately I think you're now also leading an important clinic in Bavaria, and I think now I would just be happy to hand it over to you. Thank you, Willi, for having you, and now looking forward to your presentation.
Yeah, hi. I'm also happy. I said it all right. So I tried to give you a short overview. You told it about the inpatient market. So MediClin, my clinic is part of a private hospital chain in Germany. So we have around about 50 facilities all over in Germany. We are one of the biggest provider of rehabilitations and especially psychotherapies, hospitals, and so yeah. And I'm the clinic director of one of these clinic and try to give you a small overview about the market. So you said it all right. We start with a short view about the statistics in the German market, and on the next slide you can see the hospitals and how many beds now we have, or how many hospitals. You can see we have a decreasing number of hospitals. That's really interesting because the beds are on a stable level. So that the biggest reason of this is we have better efficiency in the hospitals. And so, but this trend will go forward. So I think in the next years we become few hospitals in German market, but the beds will have on this level. And on the other hand, you only look on the hospitals. So I think a very interesting view is also a view to the rehabilitation centers. So we also have a lot of beds and clinics, and they also offer a lot of special things in their clinics. So it can be also an interesting market for companies. They will offer some special products. So in the future, you said that we will become more and more together between the inpatient, outpatient, or the different players on the market. So I think we have to come closer between these medical parts. And so I think it will become interesting in the next years. So, but I will tell this a bit later. On this slide, it's really interesting. You can see the development of the prioritization of the hospitals. So more and more hospitals are in the private ownerships, but these are the most of hospitals, but I haven't the most beds. So that's really interesting. These hospitals are often really small hospitals, and on the other hand, you will see the public hospitals. That's the few hospitals, but they have the most beds. And so interesting for Market Acesss, I think you have different partners for negotiations, and you have different decision times. On the private sector, you have often really fast decisions, but they are more money driven. And the problem is you can be out next year, but you can be very quick in. So have you a good device or a good idea, a good software, whatever, you have the CEO for negotiations, and you can have a quick win, and you can be in this year. So not every medical device or software have to be reimbursed in this sector. It's fine to if you can offer such a product. So, but that's not often the important thing. Yeah? We have a big change in the German market. The insurance don't fund everything, and so you have to earn their money from the patients, and to have to invest for future and more efficiency. So yes, that's on the one hand. On the other hand, you will have the public clinics, and I said that often really big hospitals like a university or academic hospital, and you have often very long decision ways. But if you are you often in for a long time. So you have a long partnership, for example, and you have on this hand in the first step, the negotiation partner often is the physician. You have to show or to bring the device or the software, whatever, to the physician, and then the physician of the hospital will go to his CEO and discuss it, and then you can be part of it, and you can so that's very interesting, different between these two parts of hospitals. Also in rehabilitation center or a big clinic group, I said that they are more money driven, and they're looking for quick wins to be more efficiency, and to implement new devices or new softwares, maybe to have a unique selling point in the opposite of the other clinics, for example. So the market become closer and closer. You have to be more marketing driven for the patients, and the patients more and more decided in which hospital I will go to have my operation or whatever. So yes, that's a really big point. Yeah, and now I will. You said it already. That's really interesting or really complex. The financial revenue planning in a hospital. So we did it for 1 year. So I try to show it in 3 phases. So on the first phase is the planning phase. We have it in the autumn every year. So you're evaluating your current portfolio. It's a reimbursement portfolio from the DRG catalog. It's a billing catalog in Germany, and every year we're getting a lot of new regulations from the legal or medical, and then we have to plan for the next year. What can we include? What can we change? Have we adjust our portfolio, or can we implement some new unique selling points? So you said it already, Stefan, maybe with a NUP or whatever. So the problem often is if you implement like this, you have to invest in the future, I will say, because you invested now, and mostly the insurance fund said, okay, you have to show is it a good device or whatever, and we can include it in the budget next year. So I have often the problem that we include such a product or such a software, and the insurance fund will with paying maybe 1 year later, then they can look in the retrospective, is it a good product? And then the interesting phase is the negotiation phase. It's in Germany like on a bazaar. So the insurance fund, the partners will come in the clinic, and we're sitting a whole day together, and all numbers and everything lying on the table, and we discuss it. And then we say, okay, you can include this, and then you don't make maybe another point not for the next year, or what are special points. And it's a really long discussion every year. So afterwards, so we have maybe a good way or a direction. That's the way to find the direction on this day. So afterwards, every is going home and discuss it internally. What can we make with this direction? Is it a good direction? Can we yeah, can we this for the next year? So then the dealing phase, then that's a lot of phone calls. So they often don't understand maybe a number, or they have a question more about the personnel of the hospital or whatever. And then afterwards, if everything is okay, then we will get a contract, and the contract is signed, and then yeah, that's the base for the next year. That's the budget. And yeah, I think this 3 phases roundabout, the time is, I would say, 2 months. That's normally that you have a really good contract at the end. And it's really hard every year, and become longer and longer every year, because you have a lot of more numbers and figures every year, and it's a crazy system. Yeah. And you already said that's a really good or interesting point for this year, the Hospital Future Act. Because of that, the federal government will make a big package for the digital health boost. They will invest 3 billion for the hospitals and for their digital development, because we are not a digital techies, or whatever you will say. That's we have a lot of paper in the hospitals, and they make it really inefficiency. So, and a lot of, you have to go from this way to this way, and we haven't an interaction between the in and outpatient or the other medical provider in the market. It's really hard. So every hospital or every provider is working for himself, and that's often really hard for the patients, and we haven't any informations, and so on and so on. And the next really hard way is that's a big reason in Germany, the IT security. So in the Future Act, you have to implement 50% for the IT security. And yeah, we are in the final stage, I will say, for this Hospital Future Act, because at the end of September of this year, you have to submit all your proposals, and so then you have to be fast at the moment. So interesting is that we will get the money for the next 3 years. So if you have a good software or IT system, so we will get the hardware or the software or updates, whatever is included for the next 3 years. So if you have something and you will go to the German market, time is money. So be fast and creative. So come and you can provide it. So yeah, then market perspectives. I said it. We will have a big change in the next years on the German market, because it's all over on the world the same. People become older and older. And so we have to think about new ways. So patients decide more and more by themselves in which hospital they can go in Germany. So that's really hard often. So you have to be part of the marketing. So you have to offer yourself and to show the patient what can you offer, what your unique selling points, what is your special part in the hospital. So that's the new way, and that's one of the reasons I said it on the beginning. So you have to provide special things, unique selling points in your hospital, that the patients come to you and bring the money in. So that's a big problem in the future. I will say that's German hospitals are not the marketing experts. So that's one reason, and we need a more digitalization. I said it all right, and already. So, and yeah, the point is that you have to implement a good networking between the in and out patients, and that the players on the market become closer and working more and more together. And on the other hand, what we can see in the German market, the hospitals have to more specialization by themselves. So now we have hospitals with everything in, and that's not the future in Germany. So we create hospitals with one intervention, maybe for heart diseases only, or for other points. So that is it's a big change in Germany for the next years, and we need a new reimbursement options. We're looking on worldwide reimbursement systems in Germany at this time. So because our reimbursement system is not really make for the future. People become older and older, and it's really hard to funding the system in the future. Yes, that's so a lot of changes in the market in the next years, and it will be very interesting. Yeah, I hope I could show you something. So if you have some question, please.
Perfect. Very good. Thank you, Willi. I think that was very good kind of insights, also with different kind of budget, let's say, negotiations and all of the different kind of aspects. I think also the perspective, I think, were really great, and I'm sure that we will have a couple of questions. But I think just as a conclusion, I think it's important that there are various market access pathways available for German hospitals. I think it's important to obviously have a deep look what your kind of, let's say, market looks like, which kind of pathway would also be, let's say, applicable. And Willi, you said it as well. I think it's also important which kind of stakeholder, and hence which kind of target you might even have in your mind for in terms of the hospitals. I think finally, I think there might be also different funding opportunities. Again, that might also differ a bit from the pathways, but you see it's a complex system. I think there are opportunities in there, but you need as well to really think carefully how to move into that kind of, let's say, market and pathway in order to be also successful. Lutz, back to you.
Thank you, Stefan, and thank you, Willi. That was really good informations, good look insights also from the practice from our director of the clinic, Willi Woellner, tonight. And now we are coming to the questions, and we have quite a lot of questions coming up raised by the audience. And of course, some are about the NUPs and some about the hospitals, more a little bit. And first, I want to raise the question to both of you. And I think there's already a mistake in that question. Can you confirm the NUP application needs to be submitted by the company and each hospital? So we really want to focus on who has to submit the NUP. Who has to submit the NUP? That's
yes. Thank you, Lutz. And as you said, there is already a bit of an error. Let's say it's very important that each hospital who wants to use and utilize the product or procedure, they need to submit it. A company cannot submit a NUP application. Just to clarify that as well.
Yeah, thank you, Stefan. And now the question to both of you: what is the role of the MDK, of the medizinische Dienst of the health insurances in the NUP reimbursement process for hospital products?
Willi, do you want to start with that?
Yeah, we have a big change in the role of the MD in this year on the German market. So we have a quote how many cases they can prove. So it's not a big role for the NUP, I think. They only looking for the final bill and not only for small parts of this bill. Often the problem is how long the patient is in the hospital. That's the main reason for the MD and the final bill.
Wonderful.
Yeah, and I think on top of that, obviously, it's also important. I think within the NUP submission, that is not yet a decision on the price as well, right? So on the financial part, I think, I mean, you know that as well better than more probably a lot of us as well do. I mean, a lot of hospitals as well just, let's say, submit NUPs and use that, I think, also as kind of negotiation mass, which also means that some of the NUPs are never really finally negotiated, right? So there is no Zusatzentgelt. So that's also keeping in mind, where I think maybe also that might be one of the reasons on top that the MDK might not play a major role in the NUP assessment.
Wonderful. Then there's real questions to our person from the hospital management, Willi. When are the budgets negotiated? By when are the deals closed for the next year's budget? So what's the deadline?
There isn't any deadline. So it depends of the insurance fund from hospital to hospital, from region to region. Often, and that's a really big problem. We discuss the budget for the next year, but the current year is finished, and then we discuss the budget from the next year. So often the target is at the end of the year, but honestly, often they will have these discussions at the beginning of the year. So but there is not a really hard deadline. So it depends from hospital to hospital and insurance to insurance. And yes, there is no timeline or whatever.
I think a lot of times, and I agree with you, Willi, I think a lot of times also hospitals are basically just negotiating their hospital budget or the annual budget early spring as well, right? At least for some of the hospitals, right? So around March timeline.
Yeah, the problem is you have to negotiate the budget for the coming year, but often they negotiate the budget from the last year, and that's really hard at the moment now. Yeah. But it's really complex. Yeah.
Okay, and now there are actually two questions we can actually take together. So how do you expect expensive therapies, for example, like cell or gene therapies that are like really expensive, will shape pricing and access at the hospital level?
Yeah, I mean, at the end of the day, I think we all know that I think ATMPs, where cell and gene therapies are also part of, right? They are also being, first of all, assessed within the AMNOG process, right? So I think that's the first important component. On top of that, obviously, and that might maybe be also where the question was leading towards, is that the hospital would also still need to submit, obviously, a NUP application in order to get that, let's say, price, which is then finally being as well negotiated through the AMNOG process, is then also being funded for within the hospital system. I guess where maybe the question was more leaning towards was as well how this, let's say, kind of setting of high price versus maybe sometimes lower kind of evidence because of the, let's say, natural, let's say, environment of such kind of therapies, how that might potentially be put together. And I mean, the kind of current first kind of therapies, ATMPs, I mean, what we just see is that there might be special kind of contracts also between the companies and the health insurance companies. But I personally would think, really, I think it's not so much on the pricing side for the hospitals itself, right? It might be more obviously how to manage also the bills, I guess, between hospitals and health insurances. I know that there are sometimes also some tractions, right? Yeah. But I think that's probably the kind of major thing for especially those high cost products, right?
Yes, absolutely. Yeah, I'm with you. Yeah.
Wonderful. And then we have now looking a little bit inside the hospitals about the apps you're using and the technique. There are like some questions about that. And one question is, how many solutions do you adopt in rehabilitation that are not yet reimbursed by health insurances?
That's an interesting fact, because the rehabilitation centers have another funding system. They will get money for 1 day for one patient, and every solution isn't reimbursed. So we have in the marsh of a patient, and all solutions that we offer have to be in these marsh. So we try to have there's nothing reimbursed in the rehabilitation centers. So I think it's a really interesting market for market access companies. The rehabilitation centers are more and more specialized, and the patient come from the hospital earlier, and to have to treat further in the rehabilitation centers. And yeah, we're looking for good solutions in the rehabilitation centers. And yeah, if you are efficiency and not too expensive, you can come in. And yeah, that's the last sentence of this or question. We work a lot together with startups in this case. So we try everything, and yes, it's a really interesting fact.
So that's also like another question: what is urgently needed? Patients will come more sick to a rehabilitation center and have to leave more earlier, right? Time is money, and also health insurances want to pay, like want to have the patients shorter in the rehabilitation centers. So solutions here, startup solutions, new solutions are really welcome here at your place, right?
Yeah, absolutely.
Yeah. So what could be other interesting products also that are really urgently needed by the hospitals? Or also there was another question, what are like products that can bring together these, well, we have these two worlds, right? We have the hospital world we have seen tonight, but also we have that ambulance setting here, that outpatient setting, which in Germany are two completely different worlds, right? When we're talking about reimbursement. So what could be there like interesting products that could also be there a driver for the future?
Interesting products are also to optimize the processes in the hospitals. You said time is money, so we have to be more efficiency. We have a lot of problems with good nurses or doctors to find some personnel of these, and that's really hard. So we need products to make processes really efficiency, and on the other hand, to become more and more digitization, and to get a better networking between the medical providers on the market. That's the point. So I think that's really interesting for the German market and for German hospitals, and that's currently really the way to bring all provider more and more together, to offer datas on every provider. So that's really good systems we need in the future.
Wonderful. Okay, then there's now a really nice question coming about the Krankenhauszukunftsgesetz, the Hospital Future Act here in Germany, which is like really makes you not in your tongue. So how can a medical device company with its product become part of the Krankenhauszukunftsgesetz submission? So, you know, if you want to really have a nice product and you want to be part of that digital transformation, only through a hospital or reha clinic, Stefan?
I mean, that's at least how we have seen it so far, and Willi can probably just add to that. But I think our kind of, let's say, experience was so far that obviously you need to convince the hospital that your kind of, let's say, device is an add-on, and which can help as well the hospital to basically, as Willi as well just said, to, let's say, lift your kind of digital, or the digitalization of the hospital to the next kind of level? I mean, I've just shown the different kind of buckets. You need to be, let's say, part of those buckets, and then obviously it needs to fit to the overall strategy of the hospitals as well. And I think that's basically where you could probably end it, because the hospital needs to then submit that kind of a concept. I think, Willi, anything to add here?
Yeah, only currently it's only how the name is say, Hospital Future Act is only for the hospitals in the first step. Maybe we will see the same act maybe for the rehabilitation centers in the future, but that's now a proven part. So we will see what happened, and then maybe for the rehabilitation centers we will get a same act or whatever from the legal. So yeah, and if you have a really good, interesting product, be fast. So the proposals have to be submitted at September this year. It's a really hard deadline. Yeah,
it's tomorrow.
Oh, it's almost today, right?
Yes.
So, okay. I think then we want to actually keep a little bit about that ongoing story. One person is asking about your status in your hospital, Willi. You said not digitalized, but you surely have something in the pipeline. How about, for example, an electronic patient file? Oh, we love that. We love that.
Oh, what a hard word. So yeah, in Germany we have 3 providers, honestly. So no one of these is the perfect match for us. So honestly, so that's yeah, we don't have an electronic patient file, and I think round about 50 or 60% of all hospitals haven't it yet, but they have to in the future. So that's a really hard timeline. I think in the next 3 or 5 years you have to offer such an electronic patient file. And yeah, it's really hard. So you have a lot of connections with other systems. That's I think the biggest part in these to bring all patient data in the hospital together in one system. And yeah, it's an interesting part. So the digitization in Germany, it's really bad in the was ist Vergleich?
Comparison
in the European or worldwide market.
Yes, but at least we got it tonight to get digitized and to be forever on YouTube with our webinar. So if you missed that webinar at the beginning, or you want to just recap it for your, we know that a lot of students actually of us, I mean, Stefan is also teaching at the university as I do, are listening here to our webinars. So thank you again, Willi, tonight for these wonderful insights. This was really, really a fun webinar with you. Thank you. And lots of good information, good insights, I think, for our people. And also thank you to our audience here for that wonderful questions. And thank you both, Willi and Stefan. And before we close, first, this video will also be on YouTube, as also don't check out our next webinars here. The next webinars with Professor Jürgen Wasem, the former head of the arbitration board. He will be joining us in May. Yeah. So we will negotiate a little bit with him the next questions. And also with the audience. So so that will be, and also we are talking about DIGA and about the federal Germans elections in July. You won't miss that webinar. That will be really like a crime story here. We are sitting here with green shirts. Okay, wonderful. Wonderful tonight. Thank you, Stefan. Thank you, Willi, for joining us tonight. Really good. Thank you, audience. And good night, audience. All right.
Thank you. Have a good evening. Talk to you soon.
Yeah, thank you all. Bye-bye.